It's not moving now. Okay. So anyway, this is my disclosure. And so I will start with the question one. What is the biggest challenge in 2023 caring for patient with a CLL? The answer, despite of progress, as Dr. Yassin has shown very nicely, all the guidelines, we have first line, second line, then the thing is how to sequence. This is still debatable. We have data, but all this is all historical today. So we'll discuss about the sequence. What do you know about the treatment after venetoclax-based therapy and after BTKI-based therapy and after post-IV or IA therapy? So in next 20 minutes, I sum up, all these four options. When disease relapse or refractory after chemo, after BTKI, and third step is after venetoclax, and most important, double refractory. So how we treat, and I will go all these four parts, each part 5 minutes, and I will go through 3 steps: algorithm, cutting edge data, and real world experience, and finally production. So what feature we consider sequencing the therapy? We consider age and fitness, genetic feature, tolerability of prior therapy, and we have to see the patient preference, as Dr. Yassin has mentioned, limited versus continuous, and quality of the prior and duration of prior therapy. Now, question is which guideline we use to treat hematology and how to sequence CLL treatment. So I have here put all the guidelines, we use it. But how we use for algorithm, here you can see I made it, we use NCCN guideline. And for cutting edge data, we use all the things, PubMed, local guideline, up to date. And for real world experience, I would say we use CCO Expert Online and our own cases, which I will discuss. Now, going to NCCN guideline first, in the sequence, you see I again divided into 4 parts. Part 1 is after chemoimmunotherapy. So what are options? The options are again venetoclax followed by BTKI or BTKI followed by venetoclax, depending on the treatment remission of the first chemoimmunotherapy. We will see the detail how it works. Number 2 is the patient who has taken continuous BTKI therapy. Then again, if patient has intolerance or less response, the next option is VO, venetoclax-based chemotherapy or alternative BTKI. And similarly, third part is like if patient is on venetoclax and anti-CD20, like VO-based chemotherapy, if disease come back, then what are those options? And fourth option, fourth part is, as I mentioned, double hit when the patient is refractory to all what we have, clinical trial, allogeneic transplantation, other things. So these are the things actually we'll go in detail. So first thing is, what do you know about the CIT-based treatment therapy? Once it's there, then what we should do. So this is the algorithm. We have seen an algorithm. We have now option VR-based chemotherapy, VR-based therapy, and BTKI. So the thing is, what we should do, again, I will go cutting edge of the data. If you go for resonant data, they have shown more than 600 patients. It's again, a randomized trial. They have shown more than 3 lines of the treatment, and they have chose 1/3 of the patient is the high risk as well. And this is clearly, they have shown a resonant data that the PFS is much higher, and it's about, you can say hazard ratio is 0.81, means that 79% is PFS better as compared to the chemotherapy. So if you go other BTKI, second generation BTKI, Acala versus chemotherapy after the CIT chemotherapy. So they have also included 1/3 of the patient of the high risk. And what is the result? The result, everybody know that they have shown the BTKI is much better than subsequent any other therapies. So, but the question is, which is better? First generation or second generation? Again, Elevate, RR shown they are equally same. There is no difference in the PFS, but of course there is difference of toxicity as compared to the cardio and as compared to the vascular bleeding and diarrhea. They are much better profile in second generation as compared to the first generation. Now, third thing is if you compare VR, again, venetoclax based therapy follow and versus BR chemotherapy. This is Morono trial. This is again 400 patient, and they have shown more than 50% of the high-risk patient, and prior at least 2 to 3 therapies are given prior therapies. So what they have shown, this is the 5 years the journey of the Morono trial. You have seen they have maintained continuously higher the PFS. From year 2 is almost double, then year 3, then year 4, then year 5. Here you have seen the BR has almost nil, but they are maintaining about 40% of people are still maintaining the PFS based on the Morono trial. Now, in summary of these cutting edge, what you have seen, I have put all this in the table form. This is the Morono. They have shown the PFS is 49 months, and this is the resonant one, which is 40 months. So more are they are both almost same, but here they have shown about 49 versus 40 month. We cannot compare it, but there is slightly difference in the VOS. Now, real world experience, what we do in our patients. So this was 77-year male who had history of high counts and lymph nodes. Initially, he was asymptomatic. However, we did blood flow, and they revealed this is CLL, and he has comorbid of prostate cancer and hypertension and cardiac function. Prostate cancer was actually cured. Now, thing is, after this, we have to check whether the patient has an indication of treatment or not. And there was no indication. He was observed for 2 years, 2015 to 17. Again, after 2 years, he developed symptoms. That means the patient needs to work on it. And I called as a step C. Step C is to check the cytogenetics. In this patient was checked, and the cytogenetics was intermediate. And there are some other risks as well, but in this patient has the cytogenetics was intermediate. So it was in 2017, actually, we use in this patient BR-based chemotherapy. And here you see the patient enjoyed 2 years, but after 2 years, again, the patient become symptomatic, and that time we use Abiraterone 420 milligram, again based on the resonant trial. But unfortunately, after 2 months, the patient developed multiple arrhythmias, premature complex, and the atrial fibrillation. So we held the medication, and within a month, patient become normalized. You can see this ECG. And then finally, we started BCL2 inhibitor based, that is venetoclax therapy. And he has completed therapies now, and now he is in a good PFS. So this is how I showed you the journey, how we do use it. Now, coming to the next step, what do we do after BTKI therapy now? And again, I will go through all the steps, algorithm, cutting edge. So when we start BTKI therapy, of course, first thing is side effect is problem, because off targets in both even first and second generation is there versus, venetoclax, there is only neutropenia, but here you see cardiovascular and bleeding and musculoskeletal problems. And other thing is, everybody know that Abiraterone resistant mutation happens. And in the data, it was shown that 87% patient that relapse after Abiraterone have shown BTK or PLCY2 mutation is seen. When there is 87% mutation is there, naturally it will not work. So what is the option now in these patients who have adverse effect and who develop mutation? Again, we go through cutting edge data. This is one data about 700 patients. And here they have shown that the use of venetoclax post-Abiraterone demonstrate the superior efficacy as compared to the chemoimmunotherapy. Here you see the venetoclax base is 74% and Abiraterone is 75%, and the CR is shown much higher in the venetoclax, 32% versus 5%. And here is the graph in these patients. You see this is the orange one, this is the venetoclax, PFS is still not reached, and this is the BTKI, which is lower, and then chemoimmunotherapy is the much lower. And similarly here, another graph, adalimumab versus venetoclax. Venetoclax has shown much higher as compared to the adalimumab. So in these 700 patients, they have shown venetoclax is much better than the BTKI. Then another data, cutting edge data, about 91 patients. And this also shows venetoclax monotherapy in the post-Abiraterone setting demonstrates the efficacy, which was 60%. And then third, cutting edge data from the RESONANT-2 trial, in which, when RESONANT-2 trial is the patients who have the follow-up of 8 years, the highest one in the CLL. So after ibrutinib discontinued, they use VR or venetoclax-based therapy, and they have shown 60% response rate. Now, and the fourth data, which is venetoclax for CLL progressing after ibrutinib. Again, these are 91 patients, and they have shown about 65% response after the ibrutinib failure during ibrutinib, during ibrutinib mutated patients. So they respond about 65%. Now, summary of these data I put in the table now, and here you see the green one, which is all showing about the venetoclax response, is somehow falls between 65 to 85% after ibrutinib, and these all other adalimumab and other things is between 16 to 22%. Now, some patients who have intolerance to ibrutinib, then you can use also second generation BTKI, which is acalabrutinib. They have shown good response. Here you can say 65% is shown the partial response, and overall 78% response if you find the toxicity of the patient. Now, in this second part, again, I present two cases. First one is a 52-year male who was diagnosed, again, high risk, unmutated, P53 positive. And we started in this patient continuous ibrutinib-based therapy. But after 1 year, he developed blisters, which increased from grade 1 to grade 3, despite of dose adjustment and supportive care with the dermatology. So eventually we switched the patient to acalabrutinib. Now here you can see when it was interruption, the counts and LDH went also down. Now the patient was switched to second generation, and he's doing fine now. So similarly, another patient, 83-year female who has multiple comorbidity, hypertension, hyperlipidemia, who was diagnosed in 2014. She was wait and watch. And in 2016, she became symptomatic, and she went actually in Bangkok, and there they started chemoimmunotherapy, which was BR-based chemotherapy. She enjoyed again 2.5 years. Again, she became symptomatic, and when she came here, we started actually continuous BTKI base, which was started here, ibrutinib. After 2.5 years, again, she became more symptomatic, and all the counts and lymphocyte and lymph nodes increased. Then again, in this patient, we give, based on the Marono trials, 2 years of the therapy. And here you can see the lymph nodes, all these were there in the first, and when after treatment, it become normalized. The important thing I wanted to show you here, how during the therapies, how the curves went down and how the platelets went up and the hemoglobin improved. So after 2 years of therapy, now she's off therapy and she's doing great. So this is how I showed you after BTK therapy, either you have alternative BTK or otherwise venetoclax can use it. Now, third phase of my talk is the patient who has received venetoclax-based therapy. Then what are the options? Again, I will go through the algorithm, cutting edge data, and real world practice. So everybody knows that venetoclax is the mechanism is cell death by causing the mitochondrial death. And again, venetoclax, if you give continue, there is also clonal evaluation, and it causes mutation. And these are the mutation which is formation there. So this can cause resistance. However, now coming to the data, this is the Morono-based trial in which after 48 months, 42 patients actually had no response, has relapse of the disease. So then these are the patients they were given different option, venetoclax and then BTKI and chemoimmunotherapy. And here you see the 55% patient who are given, venetoclax retreatment, they have overall response of the 55%. And similarly, the patient who are given the BTKI, they have shown 100% overall response in these patients. So this is the summary of the Morono, like 100% was shown in the BTKI and 55% was shown retreatment with the venetoclax-based therapies. And now There is another, which is still trial is in progress, named as a REVENGE. This is phase 2 study in which they are using actually venetoclax plus obinutuzumab retreatment in patients who are relapsed CLL. Everybody know VO-based chemotherapy is first line. Once is the retreatment, they are using similar VO-based therapy. 2 cohort of studies. When the study will publish, we will share it. And this is another cutting edge data. Third one, this is actually real world experience at 4 US centers, and they have shown after the venetoclax, reintroduced the venetoclax, they have shown 89% response, and ibrutinib, they have shown 55% response. And cutting edge data about CLL14, then subsequent therapy after first line therapy, they were given 2 choices, either BTKI or retreatment, and both have then actually shown the good response. 8 out of the 14 patients, they have responded, and here also 2 patients responded in this trial as well. And this another data, BTK therapy after venetoclax, they have shown similarly, and other data is 91%. And what happened if response to subsequent therapy following venetoclax or discontinuation? There are other options. BTKI is here shown 83, and some other BTKI is 53%, and TKI3 is 46%, and CAR T cell is 66%, and anti-SIDA is 32%. This is the summary of the patients. Now, this is a cutting edge a summary of all the cutting edge data which I presented. And you can see the patients who have received venetoclax and ibrutinib was given, somehow it falls from 50s to 100%. The patient who take after venetoclax, they can take BTKI. Now, the last one, part 4, is what do you know about the patient when you have given both things together, IV, means ibrutinib and venetoclax? You have done all the things. Now, what are the options remain for those patients? What retreatment data will regenerate? Again, I will go through the algorithm cutting edge. So the concept of this giving together is very simple, that BTKI binds to the BTK and switch off the cell, and they remove the cell from the bone marrow and then lymph nodes to the blood vessels. And when they come to, and then venetoclax actually acts on the mitochondria and kill the cell. So this is the combination. If you combine third one as well, CD20, which is rituximab or obinutuzumab, this is triplet in different direction. It works very nicely. Now the question is, once you have given, what are options? The options are there, like in all these trials, Capitated trial and the MEDIC-V trial, what happened? They actually use retreatment once it relapsed. Interestingly, after retreatment, the 100%, they responded very well. So this is not a thing. Now, what we do in our patient, again, real world practice of Tamam, 62-year male, patient has 17p deletion since 2010. He was doing good. He was asymptomatic. No therapy was given. When patient becomes symptomatic, he was well connected. He went to MD Anderson in 2017, actually. And there also confirmed the patient has T53 gene mutation as well. And he has a bone marrow full of the disease. There they started actually glue-based trial, which is ibrutinib and venetoclax. Here you see the curve. They started there actually first month treatment. They started over there, and then patient came back to Tamam. So we continue ibrutinib venetoclax-based therapy in 2018. And here you can see the curve went down. And he completed the 15-month therapy. Now continuously he's off therapy since 3 years, and he's doing great. Now, what is the future of these patients if it comes? Again, I mentioned there are so many options out there. We can give venetoclax plus Acala, venetoclax plus Zeno, and there is up trial which is coming in MAGIC ischemia, which is based on the actually Acala. There is option. But again, question is what happened in these patients who have double refractory? Again, this is the challenge, but where there is a will, there is a way. They found other options, non-covalent BTKI, which has 2 Brito and nimotobrutinib. This is the solution. They are upcoming, and they work in those who have mutated. And now the future direction, unmet needs in sequence. The sequential, we have seen use of sequential single agent facilitate the development of resistance. More work is needed. Ideally, there should be clinical trial, what I mentioned, these are mostly they are single line therapies or one arm, but there should be clinical trial, randomized trial, which can help us to the rationale of the guidelines, which is the option, because all these were historically available rather than scientific rational data, which I presented in all the things. In future direction, for double refractory, we have, as I mentioned, non-covalent BTKI, we have available clinical trial, which we don't have, but there are other places. And PI3K, some people use it, and some people eventually they use a T-cell therapy, which I've shown 60% response over there. And the most important thing, again, in future direction, which will help us, we call it the BH3 profiling, which allow for individualize the patient, which therapy is used for which patient, because as I mentioned, there are multiple things are there, which will hit the target and avoids the developing of the resistance is better to hit the target. So this is my last slide. So in the last 20 minutes, you have seen I have gone through the treatment after chemoimmunotherapy. I have shown you 4 cutting-edge data and my practice. And then after BTKI therapy, I showed 4 different trials and then our patient experience. And then after venetoclax, I have also shown 1 patient. And double refractory disease, I have shown the future direction, which can be possible. So I have gone through all the things by algorithm, cutting edge data, and real world experience. And my final question, which is the $1 million question, how we predict in 2023, what we should do, fixed duration or continuous therapy, and how we further sequence based on the clinical trial. Thank you very much, Dr. Xavier. Yes, please.